Today, I will present insights from an Ebola virus disease epidemic. As my colleague Francesco discussed, strategies and tools feasible for the Ebola response and acceptable to the population are needed. I will discuss three such initiatives from the 10th epidemic in the Democratic Republic of the Congo: a decentralized model of care, a triage algorithm for the prediction of Ebola infection, and a clinical database. Let's start with the decentralized model of care. Early in the epidemic, two types of Ebola health facilities were constructed in response to Ebola: treatment and transit centers. Both were centralized facilities located in larger cities, parallel to the existing medical system. Both offered Ebola testing. Patients diagnosed Ebola positive at a transit center were transferred to a treatment center for Ebola care. At both centers, patients negative for Ebola were discharged home if their condition had improved since admission, or transferred to a hospital if they required further medical care. Reluctance of the population to come to the centers contributed to delays in care seeking. To address delays, a strategy of decentralization was implemented. Decentralized centers were different from the other centers as they directly addressed needs beyond Ebola, in that patients testing negative for Ebola were not transferred to a hospital if still sick. Rather, they received non-Ebola care on site. Furthermore, they were closer to where people lived and integrated into existing local health centers. The decentralized strategy aimed to improve patient outcomes through early access to diagnosis and treatment for all diseases and reduce risk of Ebola transmission through the early isolation of cases. Now that we have discussed the different types of facilities, I will next describe the implementation of decentralized centers in the flow of patients, assess their contribution to decrease delays from symptom onset to admission, and describe the mortality of patients in Ebola health facilities. The source of data used for this evaluation includes the compiled line list from all Ebola health facilities. After matching patients transferred across different Ebola health facilities, analyses were performed on their final outcomes. The number of patients admitted per week according to the first type of Ebola health facility visited is shown here. The vertical black lines at the top of the graph represent the week of opening of a new decentralized center. Patients admitted first to a decentralized center are shown in green. Decentralized centers accounted for 12% of the more than 60,000 total admissions and 5.4% of the nearly 2,300 admissions confirmed Ebola positive. Having looked at admissions according to the first type of Ebola health facility visited, let's look next at patient trajectories across all facility types. A large volume of patients were admitted to and transferred between Ebola health facilities. The order, combination, and number of facilities visited vary greatly by patient. Looking at one of the possible trajectories, we see that out of 7,221 patients admitted to a decentralized center, 123 were confirmed Ebola positive. 93 of these confirmed patients were transferred directly to a treatment center, while 21 were first transferred to a transit center prior to any subsequent transfers. Next, let's consider our main question: how do patient characteristics and outcomes vary as a function of facility type at first admission? Let's look first at Ebola-positive patients. Among Ebola-positive patients, the mean delay from symptom onset to admission for those admitted first to a decentralized center was 3.7 days, which was shorter compared to patients admitted first to another center type. Likewise, a very high proportion, 92.4% of patients admitted first to a decentralized center received investigational treatment, and a low proportion, 40.7%, died. When looking at the final outcomes of all patients, this means that patients admitted first to a decentralized center were not at a disadvantage compared to those admitted first to a centralized center. Let's look now at the non-Ebola patients. Among non-Ebola patients, the mean time to admission was also shorter for those admitted first to a decentralized center compared to the other center types. However, there was a big difference among patients as seen by the standard deviations. In addition, when looking at the final outcomes, the proportion of non-Ebola patients who died was not higher at a decentralized center compared to the other center types. Since the vast majority of patients admitted to an Ebola health facility were diagnosed negative for Ebola, let's look at the final diagnoses of these patients. Considering all types of Ebola health facilities, the most prevalent diagnosis for non-Ebola patients was malaria. This underscores the importance of reducing delays from symptom onset to admission, not only for Ebola positive patients, but also among Ebola negative patients, as they too present with severe primary diagnoses requiring early treatment. Since early admission is so important, let's next consider predictors of delay. We assess delay from symptom onset to admission according to facility type, adjusting for date of admission, sex, and age. Non-Ebola patients are shown in blue and Ebola positive patients in red. Non-Ebola patients were admitted 15 to 20% faster to a decentralized center compared to the other center types. Ebola positive patients were admitted 20% faster to a decentralized center compared to a treatment center, but admission delays were similar for transit centers. Having looked at predictors of delay, let's next consider predictors of risk of death among the Ebola positive patients. When looking at mortality, although not statistically significant, the point estimates for patients admitted first to a decentralized center remain lower compared to those admitted first to a transit or treatment center after adjusting for delay from symptom onset to admission, treatment, and vaccination. In conclusion, decentralized centers were associated with shorter delays to admission. Even the difference of a single day can be very important to survival, underscoring the need to further reduce delays. No disadvantages were observed for patients admitted first to a decentralized center in terms of risk of death. Earlier isolation would be expected to benefit others as well through a reduction of risk of Ebola transmission. Importantly, appropriate resource allocation is needed to avoid the risk of collapsing or complicating the healthcare system with a potentially heavier decentralized model. Now that we have discussed delays to admission, let's consider delays to diagnosis from the time of admission by discussing the triage algorithm for the prediction of Ebola infection. As mentioned previously, out of more than 60,000 admissions to an Ebola health facility, 4% were confirmed Ebola positive. Patients stayed at least 3 days once admitted to an Ebola health facility, as the testing protocol required a minimum of 2 PCR tests at least 48 hours apart. To alleviate the burden on patients and Ebola health facilities, the triage algorithm was developed with the rationale to have a more efficient, easy-to-use tool to evaluate the clinical manifestations and potential Ebola exposures of patients at triage in order to identify the most important predictors of Ebola infection so that patients could ultimately be classified according to their probability of being confirmed Ebola positive. Next, I will describe the development, performance, and feasibility of the algorithm. Let's first look at its development. To develop the triage algorithm, 2 sources of data were used. The primary source was the compiled line list of patients admitted to all Ebola health facilities, and the secondary source, the chains of transmission and case investigation narratives. 12 months of data comprised of more than 22,000 non-Ebola patients and nearly 2,000 Ebola positive patients were reviewed for signs and symptoms from illness onset to admission, as well as potential exposures prior to admission, such as contact with an Ebola case. All 36 signs, symptoms, and potential exposures to Ebola evaluated at triage were analyzed. Here are those with significant associations with Ebola infection and multivariate logistic regression. Those with an adjusted odds ratio greater than 1, highlighted in red, are positive predictive of Ebola infection. Inversely, those with an adjusted odds ratio less than 1, highlighted in green, are negative predictive of Ebola infection, meaning they reflect instead other diseases common in the area. Looking at the same set of associated variables, it is important to note that we must also consider their prevalence when building the algorithm. For example, history of contact with an Ebola case was strongly associated with the likelihood of being confirmed Ebola positive, and it was highly prevalent in the population. 20% of all Ebola suspected patients and 65% of Ebola positive patients reported having had such a contact prior to the onset of symptoms. Similarly, bleeding from the gums was also strongly associated with the likelihood of being confirmed Ebola positive. On the contrary, it was not very prevalent in the population. Less than 1% of all Ebola suspected patients and only 3.9% of Ebola positive patients were reported to have had this sign from the onset of their symptoms to the date of their admission to an Ebola health facility. Now that we have considered prevalence, let's consider delay. In the previous slides, we considered the prevalence of variables regardless of delay from symptom onset to admission. However, because Ebola is a rapidly progressing disease, our hypothesis was that risk factors may vary with delay to admission, and that it was thus important to consider delay when constructing the algorithm. In each of the graphs pictured here, the vertical y-axis shows the prevalence of the variable and the horizontal x-axis shows the delay from symptom onset to admission. The orange lines in each graph represent Ebola positive patients and the black lines non-Ebola patients. The red boxes show positive predictors of Ebola and the green boxes negative predictors of Ebola. The influence of delay to admission is shown here with several examples. We see increasing prevalence of bleeding gums with increasing delay from symptom onset to admission, meaning that bleeding gums becomes more positive predictive with time. In the middle, we observe that cough affected approximately 20% of Ebola positive patients and 35% of non-Ebola patients, irrespective of the delay. Cough, therefore, appeared to be a constant negative predictor of Ebola infection. Finally, on the right, we see that the prevalence of diarrhea among non-Ebola patients was rather constant at around 30 to 35%, irrespective of delay from symptom onset to admission. In contrast, among Ebola positive patients, the prevalence of diarrhea appeared to quickly increase, becoming more positive predictive with increasing delay. Diarrhea was therefore a negative predictor of Ebola infection before day 3 and a positive predictor from day 3. From these extensive analyses, the final algorithm was developed. Two components comprise the algorithm. First, there are 4 priority variables very strongly associated with Ebola infection. These are contact with an Ebola case, having consulted an informal healer, bleeding from the gums, and bleeding at the injection site. Patients with any of these priority variables are automatically classified into the highest risk category for probability of Ebola infection. Second, the algorithm includes a scoring system to evaluate other variables with strong associations, accounting for delay from symptom onset to admission of the patient. If the delay is less than 3 days, then the scores in the left-hand column are considered. If the delay is 3 or more days, then the scores in the right-hand column are considered. After choosing the correct column, individual scores of each variable are summed to obtain an overall prediction score for the patient. Based on the total score, patients are assigned to one of the 3 risk categories: low, intermediate, and high. The next question then is how the algorithm performs. To assess the performance of the algorithm, it was first tested against retrospective data. For this, the source of data was once again the compiled line list. To ensure external validation of the tool, a different time period was used than that for the development of the algorithm. 3 months of data comprised of approximately 14,000 non-Ebola patients and 319 Ebola-positive patients were assessed. Let's look at what we found. In this graph, we present the classification of patients when applying the summed prediction score alone, that is, considering the scoring system but not the 4 priority variables. The bars represent the total number of patients in each score according to their delay. In gray, those admitted within 2 days of symptom onset. In black, those admitted 3 or more days following symptom onset. The lines in the figure represent the proportion of patients for each summed score who were confirmed Ebola positive. The light blue line with gray circles shows those presenting early, and the dark blue line with squares are those presenting late. Looking at the bars, we see that the distribution of patients in each score is shifted to the right for late notifications. The scores obtained are on average higher for these patients. Importantly, in both groups, there is a continuous increase in the proportion of Ebola-positive patients with the prediction score. While not pictured here, when we also consider the priority variables, 3 times more patients are assigned to the high-risk category than with the score alone, further improving algorithm performance. We can see, therefore, that from a complex combination of symptoms, the algorithm allows us to classify patients according to their probability of infection. In addition to the evaluation against retrospective data, an evaluation against prospective data was conducted in North Kivu province and continues today in Equateur province, where the 11th Ebola epidemic in the Democratic Republic of the Congo is ongoing. While there is no time today for a detailed discussion, initial results show good performance of the algorithm in terms of its ability to predict Ebola status. Healthcare workers also find it easy to use and understand. In summary, the triage algorithm is a promising tool with many potential benefits. During periods of high occupancy, the classification of patients according to their probability of being confirmed Ebola positive may allow priority testing for certain patients. This could result in high-risk patients starting Ebola treatment earlier and low-risk patients starting non-Ebola treatment earlier. In addition, grouping patients based on their probability of being confirmed Ebola positive may benefit all patients and staff through reduced risk of Ebola transmission during isolation, even though we hope that transmission within an Ebola health facility would not occur. The algorithm may also facilitate case management strategies adapted to a patient's risk category, potentially reducing burden to patients in Ebola health facilities. A future step is the incorporation of rapid diagnostic testing in the triage algorithm. This may be especially useful in remote areas with limited access to PCR testing. As the algorithm helps with early identification of Ebola positive cases, let's look now at a tool that helps with the early identification of deterioration among these cases, the clinical database. The clinical database was developed to digitalize for the first time across an entire Ebola epidemic extensive clinical data on all patients over the course of their hospitalization, including signs and symptoms, biochemistries, cycle threshold values, and prescribed treatments. The rationale was to identify signs, symptoms, and trends of deterioration among patients to allow early and adapted supportive interventions by clinicians in order to inform Ebola care. In collaboration with the Ministry of Health, patient medical files were obtained from all Ebola treatment centers for retrospective data entry. As data entry and analysis of the clinical database are ongoing, today's presentation includes only a few early results from 610 Ebola-positive patients. This is only a fraction of the clinical data that will ultimately be digitalized for more than 2,200 Ebola-positive patients. I will focus on three variables for today's presentation to provide a snapshot of what the database will offer. Let's first look at an analysis of patient vital signs. This figure plots the respiratory rates of Ebola-positive adult patients over the course of their hospitalization. On the left are patients who survived, on the right, patients who died. We observed that compared to those who survived, respiratory rates were elevated among those who died, and the trend worsened over time. Elevated respiratory rate is an early and sensitive sign of hypovolemic shock or sepsis. We also assessed the heart rate of Ebola-positive adult patients over the course of their hospitalization. We see the same trend. Heart rate was elevated among those who died and worsened over time. Elevated heart rate is another early and sensitive sign of hypovolemic shock or sepsis. Now let's look at patient biochemistry. We analyzed creatine kinase levels of Ebola-positive patients over the course of their hospitalization. We find that creatine kinase levels were elevated among those who died compared to those who survived. Elevated creatine kinase is an indicator of rhabdomyolysis, which has been previously noted as a prevalent consequence of severe Ebola. Elevated respiratory rate, heart rate, and creatine kinase are sensitive known indicators of hypovolemic shock, sepsis, and rhabdomyolysis, which are all established consequences of severe Ebola. What is novel is that we can now observe their trends over time. This presentation includes only a very small subset of data, offering an early look at the potential of the clinical database. Once all clinical data are digitalized, Ebola care can be further improved by developing an Ebola-specific score of severity for the early detection of potential deterioration of Ebola-positive patients. This can help clinicians identify deterioration in patients at an early, reversible state in order to prevent death. By comparing trends and the outcomes of different supportive care interventions that were used in Ebola treatment centers during this epidemic, in the future, the database can also facilitate a clinician's choice of supportive care interventions and improve the monitoring and adjustment of these interventions. For example, the ratio of intravenous fluids and vasopressors given to a patient. Implementation of the clinical database in real time in future epidemics constitutes another opportunity to further improve Ebola care. In closing, a few final remarks. First, especially in settings with wide geographic dispersion of cases and difficult access, such as in Equator province, a decentralized model of care may further reduce delays to admission. Additionally, the triage algorithm can help prioritize patients at greatest risk of being confirmed Ebola positive and may accelerate access to treatment, especially with integration of rapid diagnostic tests into the algorithm itself. Second, the findings from the clinical database can allow early detection of deterioration among Ebola-positive patients to facilitate rapid and adapted supportive care interventions. Third, it is important that we continue to critically evaluate tools and strategies to further adapt the Ebola response to varied contexts and populations. Thank you very much.